So this is a 50 years old female who presented to the emergency department with the CAD and STEMI. Troponin was markedly positive, and she was taken for the angiogram. On the LV, on echo, the LV function was normal, and this was the angiogram. You can see how large and ectatic LCX and LAD was, and you can see the large thrombus burden in the proximal LCX and the significant stenosis in the distal LCX, and LCX was dominant and ectatic. So this is a apicaudal view, and you can see the appreciate the same thing in this, and you can see the how large burden of thrombus was there in the LCX. So what should be the plan in such a case, whether to start the GP2B3 inhibitor and all, and what what is the ideal plan in this case? In such a, you can see the proximal LCX is almost, this is RC and was normal codominant, and you can see this case in this LCX is almost around 5.5 to 6 in the proximal, and distally probably a 4. So after all clearance, we decided to do angioplasty to the proximal LCX and the distal LCX. The largest size of stent available was 4.5 on shelf. So we decided to put a 4O stent in the distal LCX and 4.5 and planned stage aggressive post dilatation with the 5.5 balloon in the proximal LCX. So after all clearance, we decided to proceed the angioplasty. This was the right radial route with this JL catheter, because you can see the short LM was there, so it would be wise to use the JL catheter. And so we started with this right radial route, and with this JL catheter, and this was the BMW PTCA wire. It was a cinch to cross the wire. So in such a large ectatic artery, it has been always a problem of stent size, because, and this was a 4O stent which we deployed in the distal LCX. This was the positioning of the stent. So deployed at around 22 atmospheric pressure, it was the RBP, and you can see some under deployment, under expansion of the stent. So we did the NC for that later after the proximal stent, and then we positioned the 4.5 stent in this proximal LCX, and we deployed at the RBP pressure. It was a 22 atmospheric pressure. You can see, so deployed at around 22 atmospheric pressure. So obviously after stent deployment, there was a under expansion because the artery size was almost around 5.5 to 6. So here you can see the gross under expansion of the stent. So obviously we decided to do aggressive post dilatation. So we proceeded with the 5.5 balloon. This was a 5.5 balloon, and we post dilated with this 5.5 NC balloon at almost more than RBP pressure. It was 26 atmospheric pressure, and you can see in this stent boost. So unfortunately this balloon got ruptured while dilating the balloon, but fortunately nothing has happened to the patients, and this is the picture after the NC. So it was acceptable result, and we accepted this result, and we did the NC at the distal LCX also. So this was a very difficult decision in such a large ectatic vessels. Uh, we had largest stent available on shelf was a 4.5, so we had to do with that stent, and then we planned for the aggressive dilatation, but fortunately nothing has happened while balloon ruptured. And this is the final picture after the NC in the distal and proximal LCX. So this has been always a problem in large ectatic vessels, the availability of stent and all. So this was the angioplasty to this LCX.